Hi guys, this chapter is going to focus on acid-base imbalances. We are following up after we've talked about our fluid and electrolyte imbalances, and we're going to look at the basic concepts of acid-base. You're going to go a lot more in depth than this when you get into your HR course. So we're just going to hit the surface so that when you see it in HR, it makes a little bit more sense. So let's get started here. So people can develop acid-base imbalances when their normal homeostatic mechanisms are dysfunctional or overwhelmed. So our normal mechanisms have become overwhelmed and they can no longer compensate. The body is always compensating for things, but because it's overwhelmed, it may not have this capability. Something has happened where the body can't compensate. Something like anxiety is a really great example. Think about when you get anxious. Our breathing gets quick, more rapid, and this increase can actually change our acid-base imbalance. So we must decrease, slow our breathing down to help compensate or help our body fight against that. Although there are many processes that occur to try and create balance, the imbalance of hydrogen ions really determines that pH, and it can cause an acid-base impairment. So it's all about the hydrogen and how those hydrogen ions are fluctuating that can create that acid-base imbalance. Acid is that substance containing hydrogen ions that can be liberated or released, and then base is that substance that can trap those hydrogen ions. And those are just some quick definitions to be aware of. So acid-base imbalances. Those can occur when carbonic acid or bicarbonate levels become disproportionate. Respiratory acidosis and respiratory alkalosis are our two respiratory ones. Metabolic ones are metabolic acidosis and metabolic alkalosis. Respiratory acidosis is an excess of carbonic acid in our extracellular fluid. Respiratory alkalosis is the deficit of that carbonic acid. Metabolic acidosis is deficit of our bicarb, and metabolic alkalosis is excess of bicarb. And this is going to make a little bit more sense when we start interpreting these values. So when we're determining our abnormal values, we want to think and look at CO2, or our carbon dioxide, and HCO3, which is our bicarb. Carbon dioxide is the respiratory component of an ABG, and that's really important to remember. If you hear carbon dioxide, you should relate it back to respiratory. If it's low and the pH is high, the patient is in respiratory alkalosis because they move in different directions. On the bicarb side, the bicarb is the metabolic component of the ABG. So you want to be thinking kidneys. If it is low and the pH is low, the patient is in metabolic acidosis because they are equal. They move in the same direction. So let's just keep talking here. So our parameters are here. as you need to memorize these. These are things you need to know because you need to know those normal values. The pH, the normal pH is 7.35 to 7.45. Your carbon dioxide is 35 to 45, and your HCO3 or your bicarb is 21 to 26. Now understand that some of the bicarb is the one I see most often that kind of fluctuates. You may see it 21 to 28, but for the most part 21 to 26 is a really good normal range for you to remember. So alkalosis, you're kicking up the pH. That means it's above 7.45. Acidosis, if you think about the D in acidosis, it's the downhill slide. So it's below 7.35. So K is alkalosis, it's kicking up the pH. Acidosis, D, is on the downhill slide. So that is the last name of our ABG result. The first name will be our compensation. Is it compensated? Is it uncompensated? Is it partially compensated? The middle name is going to indicate, are we dealing with a respiratory issue or a metabolic issue? The last name of your ABG is your acidosis versus alkalosis. So is it acidotic, meaning the pH is falling below the 7.35, or is it alkalosis, meaning it's kicked up and it's greater than the 7.45? Let's just keep talking, guys. So let's talk about acidosis specifically. What are some causes of respiratory acidosis? That is, what's going to cause my body and lungs to retain an excess amount of carbon dioxide. So anything that retains that excess carbon dioxide, things like asthma, COPD, restrictive lung disease, excessive sedation. So if we're sedating our patient with lots of medication, that's going to retain that CO2, right? We're not breathing it off. So what are some causes of metabolic acidosis? That is what will cause our body or our kidneys to retain inadequate amounts of HCO3. So we can think about ingestion of toxins. Maybe they have attempted suicide and they have an overdose of drugs in their system. Maybe they have uncontrolled diabetes. The kidneys are in some way retaining an inadequate amount of bicarb. So both of those things will make our patients acidosis. Respiratory is retaining excessive amount. The kidneys have an inadequate amount of CO3, HCO3. So this is just another slide. Sorry, it's a little fuzzy there. Respiratory acidosis, hypoventilation. They're not breathing enough. They're retaining that CO2. So you can see some of the causes of our respiratory acidosis. Drug overdose might be one, pulmonary edema, COPD, asthma, right? We talked about all of those. If our patient is metabolic acidosis, remember our pH is less than 7.35, the bicarb is being depleted. Therefore, the pH is dropping. And our focus for this one is DKA, maybe again an aspirin overdose or some type of toxin, shock, renal failure are all big ones to indicate that we might be in metabolic acidosis. So again, respiratory acidosis, hypoventilation, retaining that CO2, they're becoming very acidic. So increased incidence of dysrhythmias because we're holding on to some of that potassium. And we can remember from our fluid and electrolytes, if we have potassium that is out of whack, right, we're concerned about cardiac. And then here's our metabolic acidosis. Eek, that one's pretty fuzzy too. Some signs and symptoms here, change in level of consciousness, maybe Kussmaul's respirations, and that's a compensatory mechanism of hyperventilation that we usually see with our DKA patients. It's trying to make up the difference. A lot of times you're going to have a really nice fruit-smelling breath. A lot of times it's so overpowering when you walk into the room, you're going to smell that fruity smell. So let's switch gears here and talk about alkalosis. So what are some causes of respiratory alkalosis? So that means what is causing our body or our lungs to excrete CO2, too much CO2. That can be hyperventilation, right? We're really anxious, we're breathing fast, we're excreting that CO2 really fast. Mechanical ventilation is another one. Maybe the settings aren't set properly. Ingestion or toxins in the body could also cause us to excrete too much CO2. On the metabolic side, what are some causes that would allow our kidneys to retain excessive amounts of HCO3 or our bicarb? So anything that's causing our kidneys to retain too much bicarb. So Tums have a huge amount of bicarb. So if we're popping Tums a lot, that's an excessive eating of Tums. That can cause too much bicarb. Or maybe our patient has pulled out their gastric acids from an NG tube, right? Prolonged vomiting, we have suctioning set too high or for too long. Both of those can cause metabolic alkalosis, meaning we're retaining an excessive amount of HCO3. So here's respiratory alkalosis one more time. Hyperventilation is the most common cause. Remember our anxious patient. You can also see seizures, deep rapid ventilation. It creates potassium issues because the potassium can drop. So once that potassium drops, what do we get concerned about? Our cardiac issues. And then here's just another follow-up on metabolic alkalosis. You can again see those signs and symptoms. They could be restless to fatigued. You could see hypokalemia, which again, we're going to be concerned about that cardiac. Severe vomiting, GI suctioning, diuretics, excessive antacids, again, are going to cause that metabolic alkalosis. So what is compensation? Remember, we've said the first name of our ABG is going to be compensation. So this is the process by which the acid-base imbalances are overcome. So my body's trying to bring me back in that health range, that homeostasis range. In the event that the acid-base imbalance is respiratory in origin, the kidneys are going to attempt to compensate, right? Primarily by regulating that bicarb. In the event that acid-base imbalances are metabolic in nature, so the flip side of that, then the lungs are going to attempt to compensate, primarily by regulating the CO2. The ultimate goal is restoration of normal pH. So that's getting that pH between 7.35 and 7.45. That is the ultimate goal. So here's our basically perfect patient. They have a pH of 7.4. It meets right in the middle of that 7.35 to 7.45, meaning our patient has been compensated. The pH is normal. Whatever's happening with our respiratory and our metabolic numbers, the pH is now normal, meaning our patient has been able to compensate. So remember, when it gets confusing, go back to Rome. Respiratory opposite, metabolic equal. So in this slide just shows kind of a recap of the goal of our ABG analysis. So we want to make sure when we're looking at our lab values, do we recognize that it is either acidosis or alkalosis, right? That's our pH number. If our pH is down, it's acidosis. If it's kicked up, it's alkalosis. We also want to recognize, is this a metabolic issue or a respiratory issue? And then the last one is, what is their compensation? Are they fully compensated, partially compensated, or uncompensated? So remembering that compensation is that overcoming that imbalance. So they are considered fully compensated if the pH is normal. Remember our perfect patient at 7.4, they are fully compensated because whatever's happening, it has compensated and the pH is normal. If all three values are abnormal, our respiratory CO2 is abnormal, our metabolic HCO3 is abnormal, and our pH are abnormal, then our patient is considered partially compensated. If the CO2 and the HCO3 are normal, but the pH is abnormal, then it's considered uncompensated. So I'm going to say it one more time. When it gets confusing, go to Rome. Respiratory opposite, metabolic equal. And we are going to discuss this in really great detail during class before we take our exam. If you have any questions, you can shoot me an email. Otherwise, you can chat about it in class. Thanks, guys.